Thanks so much. Okay, great. Well, I'm really excited to see so many people in person today and to give you an update on our GD2 CAR T-cell clinical trial. I am the opening act. I'm just going to give kind of the background and introduction, and then Dr. Mahdi is going to take over and give you some exciting updates about the trial. Here are our disclosures. So, as this, oh, am I not mic'd? Is this better? Thank you. So as I was saying, I will be the opening act, giving some background and introduction, and then Dr. Mahdi will be taking over. As this audience knows well, H3K27M altered diffuse midline gliomas are a terrible, terrible family of diseases. These account for about half of all pediatric high-grade gliomas. For diffuse intrinsic pontine glioma, the most common form of diffuse midline gliomas, the median age of onset is 7 years of age. But I think it's really important, we've learned over the last several years that these are tumors that really can happen at any age. And increasingly, as we have better diagnostics for these malignancies, we're seeing both DIPG and spinal cord DMG, as well as the third neuroanatomical location where these can occur in the thalamus. We're seeing these tumors in adults, and not just in young adults, but sometimes in aged adults. So this is really a diagnosis to keep in mind whenever there is a tumor in a midline structure. For diffuse intrinsic pontine glioma and those tumors occurring in the thalamus and spinal cord, these are malignancies that strike about 200 to 400 children each year in the US alone, and represent the leading cause of brain tumor-related death. These are universally fatal malignancies with a median survival of only 10 to 11 months for DIPG and about 13 months for diffuse midline gliomas outside of the brainstem. This consists of about 6 to 7 months of progression-free survival after diagnosis and upfront standard radiation, and then 2 to 3 months of post-progression survival. Right now, radiation therapy is the only standard. And studying this disease for many years now, we've discovered some new things about it, that diffuse midline gliomas especially, but also all gliomas, integrate in structural and electrical ways with the neural circuits that they invade. We find that the activity of the nervous system very robustly drives these cancers, that the tumors form bona fide neuron to glioma synapses, and you can see that ultrastructurally here, and that drives electrical currents into a network of tumor cells. So given that these are tumors that are structurally and electrically integrating into the nervous system that we cannot surgically remove, and that are protected and augmented by these interactions, how on earth are we ever going to get rid of them? Well, one idea is that we could therapeutically disintegrate these cancers, perhaps, by leveraging the power of the immune system. And so kind of in parallel, understanding the neuroscience of these cancers really prompted us to try to understand immuno-oncology strategies to very precisely, hopefully, target these cells and use the immune system to fight them. And so a number of years ago, using patient-derived diffuse midline glioma cell cultures and xenograft mouse models, my laboratory identified a really interesting target on the surface of DIPG cells. Doing a cell surface screen, we found that all of the tumors that express the H3K27M mutation, which defines this malignancy and is present in more than 80% of the tumors, that all of those tumors that have that mutation have extraordinarily high expression of a disialoganglioside called GD2. This is a sugar moiety, and the enzymes that make GD2 are upregulated very, very robustly by the histone mutation and the consequent epigenetic dysregulation. And so this was a really exciting finding because this is a target present on all of the tumor cells, expressed at very, very high and uniform levels. And extra exciting, being at Stanford, was that Crystal Mackall, a real leader in cancer immunotherapy and a pioneer in CAR T-cell therapy, had recently moved to Stanford when we made this discovery, and her laboratory had developed a sort of next generation optimized GD2 targeting CAR T-cell. For those if there is anybody in the audience who's unfamiliar with CAR T-cell therapy, this has been really revolutionary for hematological malignancies, and is emerging as a really exciting strategy for solid tumors. And what CAR T-cells enable is the specific targeting of a particular antigen through the expression of these chimeric antigen receptors that have been engineered such that on kind of the business end of the molecule, there is an antibody fragment that specifically recognizes one antigen, in this case, GD2. And that recognition or binding domain is fused to the co-stimulatory domains required for T-cell activation. So once the T-cell sees the antigen, it is in the same step activated and can become cytotoxic. And when we put Crystal's CAR T-cells into our patient-derived xenograft mouse models of diffuse midline gliomas, we saw that they just, between 1 and 2 weeks after IV administration, cleared the tumors. And I have to be honest, having developed these models, having worked with them for 15 years, I've never seen anything else clear a tumor like this. This is in contrast to control CAR T-cells that were administered to mice in a control group that would not be expected to interact with this tumor type. And when we look microscopically, we see these purple labeled CAR T-cells kind of emerging around 1 week after IV administration around the brainstem in the sort of leptomeningeal vasculature, and then infiltrate into the tumor. Here, these green cells represent tumor cells. And by 14 days, the T cells are throughout the brainstem and the tumor cells are gone. And looking at an area of more dense tumor at a later stage, you see these purple and green tumor cells diffusely infiltrating the mouse brain, the mouse cerebellum, and following GD2 CAR T-cell therapy, those are eradicated. And when we look at the overall survival of the mice, we see that the mice that survived the therapy, and that's a really important caveat, were for all, as far as we can measure, cured. But not all mice survived the therapy. When we examined those mice, what we found was that the tumor inflammation in an already expanded brainstem caused obstructive hydrocephalus, and the mice died from herniation, being left in a, not in a mouse neuro ICU, not carefully enough monitored in the mouse facility. And so this was perhaps not unexpected, given what we know about the anatomy of the brainstem and the flow of CSF, but it was a really important harbinger of what we might see in the trial, and helped us really take some pause and design the trial with neurocritical care considerations very much in mind. And then excitingly, just at the very beginning of the pandemic, in June of 2020, we opened this phase 1 clinical trial of autologous, meaning taking the patient's own lymphocytes to generate the CAR T-cells, CAR T-cell therapy, the first one in the world for diffuse intrinsic pontine glioma. And I would love to hand things over to Dr. Mahdi to tell you about our experience over the last 3 years on this trial.
Thank you so much. So I wanted to transition to talking about the GD2 CAR T trial itself. The few things about the eligibility criteria that I wanted to highlight was, first is that we are taking up to 2 years to 50 years. So we are in the process of opening the GD2 CAR T trial in the adult hospital, and we're excited to collaborate more with all of you to help take care of these patients. The second eligibility criteria that I wanted to highlight was that all patients undergo standard of care, and all patients must have a tissue diagnosis of H3K27M, because as Dr. Monje illustrated, only those patients will express GD2 on the surface of their tumor. Furthermore, all patients must have localized disease that does not extend to the cerebellum or thalamus or have significant medullary dysfunction because of the risk for perilous inflammation at those sites that was predicted in the preclinical models. This is the treatment and monitoring plan for the patients on arm A. So all patients undergo apheresis, and while their cells are being manufactured, they undergo placement of a Maya reservoir. This reservoir acts as a safety pop-up valve in the case of increased intracranial pressure, as was predicted in the preclinical models, and it is also a way that we deliver the cells intracerebroventricularly. Patients come back for lymphodepleting chemotherapy for 3 days, followed by a day of rest, and then undergo an IV GD2 CAR T infusion. If they have either clinical or radiographic benefit from that IV infusion, they are then eligible for ICV infusions, which can be repeated every 4 to 6 weeks for up to 18 infusions. There are 3 main CAR T toxicities associated with this trial. The first is cytokine release syndrome, which is associated with fevers, hypotension, and hypoxia. This was very common after IV administration of CAR T-cells, but not common after ICV administration. The second is a generalized systemic neurotoxicity called immune effector cell-associated neurotoxicity, which can clinically present with tremor, dysgraphia, aphasia, seizures. And interestingly, this was quite rare on our trial. The most common toxicity that we saw was a localized neurotoxicity, which we termed tumor inflammation-associated neurotoxicity. And this represented on-target neurotoxicity related to either mechanical space constraints or neural circuit electrical physiological dysfunction. From a mechanistic perspective, there are 2 types of tumor inflammation-associated toxicity. From a mechanical perspective, you would have inflammation-induced mass effect that leads to edema with tissue shifts, leading to obstruction of CSF flow and increased intracranial pressure. And the second type of TN is an electrical issue where you have inflammation-induced neural circuit dysfunction, where you can have worsening of existing neurological deficits due to that local neural dysfunction, or develop new deficits as well. The mechanical TN develops because, as you all know, the Monje doctrine defines that the skull is non-compressible and the volume of the intracranial cavity must remain constant. Thus, when you have immunotherapy-induced inflammation, you can have impingement on surrounding structures, and that mass effect can cause obstruction of CSF flow and result in increased intracranial pressure. Because you have mass-induced edema, it encompasses the concept of pseudoprogression, which is a common post-treatment phenomenon that's sometimes seen after radiation. Because you are dealing with mass effect in very delicate areas, if untreated, mechanical TN can lead to herniation and then death. So therefore, it is a neurological emergency. I wanted to go through a case of type 1 TN, where at baseline you have a patient who has a pontine glioma that's effacing the 4th ventricle, and 2 days after receiving an ICV dose of CAR T therapy, this patient, in the context of having grade 1 CRS, became acutely somnolent and developed a new right third nerve palsy where his eye became down and out, and he had intermittent dilation of his pupil. His Ommaya was accessed, and he had an elevated intracranial pressure of 36 millimeters of mercury, and CSF was removed with immediate clinical improvement. The Ommaya was left accessed using a butterfly needle to allow for continuous CSF drainage and ICP monitoring. With this accessing and with steroids, his clinical picture improved and overall was consistent with inflammation of his pontine tumor causing early stage uncal herniation with obstructive hydrocephalus. We obtained a CT scan at the time of his peak inflammation, and we saw that he had mild expansion of his lateral ventricles and just slightly more increased compression of his 4th ventricle. As you might all be gathering, is that this imaging is not particularly striking and illustrates how the radiographic findings of TN do not necessarily correlate with the clinical picture, and your clinical exam is going to be the most important thing that guides your management. In comparison, type 2 or electrical TN occurs when you have transient neural dysfunction of the circuits involved in the tumor. This causes transient worsening of existing neurological symptoms, and sometimes you can develop new neurological symptoms because the CAR T therapy can be finding tumor that you may not yet appreciate on MRI. Importantly, this occurs in the absence of peritumoral edema and therefore is distinct from pseudoprogression. Similar to mechanical TN, though, neuroimaging can sometimes show increased T2 signal indicative of local inflammation, or it could be completely normal. Electrical TN can be managed conservatively unless it involves lower brainstem or phrenic nerve function, such as respiratory drive. To describe a case of type 2 TN, we have a patient who had a DIPG, and as you can see, it involves his trigeminal nerve nucleus. And clinically, he had left trigeminal nerve dysfunction at baseline with left face numbness and ability to open his mouth fully. He was only able to take small bites. On day 7, during the period of peak inflammation in CRS, he had worsening of his left trigeminal nerve dysfunction with more severe left facial numbness, and he could only open his mouth to drink by straw. And at that time, we saw slightly increased T2 signal of that trigeminal nerve nucleus. By day 14, when his inflammation had begun to improve, we also saw resolution of that increased T2 signal and improvement of his left trigeminal nerve function, where he had improved facial numbness and was able to open his mouth actually better than baseline. And by day 21, we had complete normalization of that area of T2 signal of his trigeminal nerve nucleus. And he had normalization of his facial sensation and was able to open his mouth fully and eat hamburgers, which was the only food he would eat at our hospital. So in taking guidance from the ASTCT, which have defined consensus guidelines for ICANS and CRS, in collaboration with others across the US and internationally, we created guidelines to have a grading scale for TN. This grading scale, we can go through in detail. In grade 1, TN consists of either headaches associated with fevers or mild worsening of existing neurological symptoms or new symptoms that aren't affecting function. The reason why fevers are a part of TN is all fevers originate from the hypothalamus that can be mediated by either central or peripheral cytokines. Now in CRS, you have more systemic inflammation and you have those fevers just driven by the systemic inflammation. In comparison, TN is more of a localized process, and so you have fevers that are originating from more of that central cytokine process. Grade 2 TN occurs when you have moderate changes in your neurological exam that begin to affect function. And then grade 3 TN is when you have severe neurological symptoms that are starting to affect critical cardiopulmonary functions, or if you're developing increased intracranial pressure that is responsive to intervention. You develop grade 4 TN when you have life-threatening, clinically significant elevated intracranial pressure that is refractory to CSF drainage, or if you're having such severe cardiopulmonary dysfunction that you have a need for endotracheal intubation or mechanical ventilation. Grade 4 TN also occurs when you have signs of impending herniation. Importantly, this grading scale encompasses both type 1 and type 2 TN. Now, traditionally speaking, most commonly, type 1 or mechanical TN is associated with higher grade TN, and electrical TN is associated with lower grade TN. However, you can have high grade electrical TN if you're affecting critical cardiorespiratory function. In terms of the management of TN, some of you are quite familiar with our management, but just to go over it, for grade 1 TN, we just observe the symptomatic management. And grade 2 TN, because you're starting to have affecting of your neurological function, we consider treatment with anakinra. Anakinra is an IL-1 receptor antagonist, and we feel like it helps treat the inflammation, and it also helps prevent the worsening of inflammation. We don't believe that there's a role for tocilizumab, which acts on IL-6 and is commonly used in CRS, because this is a large molecule that does not cross the blood-brain barrier and therefore would not really be effective in TN. Grade 3 TN management consists of the standard neurocritical care measures for increased intracranial pressure, with a caveat that we also have CSF removal through the OMIA. And from an inflammation perspective, we can increase the anakinra dose, which we have found to be quite helpful, and we can also give dexamethasone. We are judicious in our use of dexamethasone because it has been shown that for a variety of immunotherapies, dexamethasone can decrease efficacy of that therapy. But when it is indicated, we are quick to use it because we have to keep patients safe first and foremost. Grade 3 TN management can also include cardiorespiratory support with CPAP and BiPAP when clinically indicated. For grade 4 TN, because you're having CSF increases in your intracranial pressure that are refractory to drainage, sometimes you need to have urgent neurosurgical intervention with either EVD placement or shunt placement. And we consider higher doses of dexamethasone and sometimes have used intra-OMIA hydrocortisone as well. And if needed, from a respiratory perspective, patients can sometimes need to be intubated and mechanically ventilated with grade 4 TN. I now wanted to transition to talking about our clinical updates for dose levels 1 and 2 on Arm A with a data cutoff of December 1st, 2022. So the first 4 patients on dose level 1 were incredibly informative to our understanding of the clinical trial and its potential. There were 3 patients with DIPG that were treated on dose level 1, and 1 patient with a spinal cord DMG who unfortunately had rapid progression between time of enrollment and treatment and was treated on a compassionate basis. 3 out of 4 patients had clinical and radiographic benefit and went on to receive an ICV infusion. And importantly, we saw that all the toxicities that were observed were manageable and reversible, and there was no on-target, off-tumor toxicity, which was an important finding given that GD2 is expressed on other tissues. We saw that ICV infusions were associated with less systemic toxicity and a more pro-inflammatory and decreased immunosuppressive cell population state. We also learned from the first 4 patients that it was possible for these patients to have clinical and radiographic benefit from this trial. This is a 21-year-old male with DIPG who received 1 IV infusion and 4 ICV infusions. At baseline, as you can tell, he has significant tumor involving his medulla. And just 2 weeks after his infusion, we saw a significant reduction in that tumor volume. At baseline, he had a pretty dense left facial nerve palsy, and 2 weeks after his ICV infusion, he had normalization of his smile. Additionally, at baseline, he had a very wide-based ataxic gait with right leg circumflexion. As you can tell, he's having difficulty making turns. He is having difficulty toe walking and was not able to tandem and quickly fell over. Just 2 weeks later, he was walking with a much narrower gait with less right leg circumflexion. He had smoother turns, and although he came into the hospital with a wheelchair, he walked out of the hospital independently and was able to go on a hike with his family. It's very impressive. After completing the first 4 patients on dose level 1, we then finished dose level 1, or arm A, with a total of 13 patients being enrolled. The median time from diagnosis to enrollment was 5 months, and there were 8 patients who were already in disease progression prior to their first infusion. There were 3 patients on study that were treated on dose level 1 and 8 patients treated on dose level 2. 9 out of 11 patients had clinical or radiographic benefit, and then received additional ICV infusions with a median of 4 ICV infusions per patient. These graphs show the RMA toxicities that we saw. So for CRS, as you can see, it was most commonly seen after the first IV infusion and was associated with higher grades with the IV infusions when compared to ICV infusions. There were 3 dose-limiting toxicities seen with dose level 2 related to grade 4 CRS with the IV infusion. In comparison with ICANS, it was only seen after the IV infusion, and there were no DLTs associated with ICANS. In terms of TN, it was most severe earlier on in the course with the first IV and then the first ICV infusion, but then typically the grades decreased over time. And there were no DLTs attributed to TN. Now, you might notice that we do have patients who had grade 4 TN, but it did not constitute a DLT because we had predicted that these patients would have severe neurotoxicity given the localized neuroinflammation. And we had, in our IRB protocol, it said that if patients had grade 4 TN for less than 96 hours, it did not constitute a DLT. This waterfall plot shows the best overall radiographic response for the infused subjects on RMA. Although there were 3 patients who did not have radiographic benefit, the remainder did, and there were 4 patients who had over a 50% reduction in their tumor volume, with 1 patient having a complete response. This swimmer's plot shows that the median overall survival from diagnosis was 20.6 months. When you break down DIPG versus spinal cord DMG, the overall survival for DIPG was 17.6 months, and the overall survival for spinal cord DMG was 27.3 months. There was a median post-progression survival of 9.7 months, and at the time of the data cutoff, there were 4 patients who were still alive, 2 of whom were still receiving ongoing treatment. Because a complete response in the world of DIPG is something that is to be celebrated, I wanted to dive a little bit deeper into this patient. He's a 16-year-old with DIPG who's received 12 infusions, At baseline, he had a tumor that involved his midbrain, his pons, and his medulla. At 3 months, we had already begun to see significant improvement. As you can see, his midbrain has normalized. He had significant reduction in his pons, with just some residual tumor around his biopsy tract and some slight tumor in his medulla. By 5 months, he had continued tumor reduction and had only just that residual disease around his biopsy tract in the medulla. And then by 13 months, he had had normalization of his midbrain, the tissue that was surrounding his biopsy tract, and his medullary involvement. And you do see some residual T2 signal, but we believe that's related to the biopsy tract itself and likely is related to gliosis. This CR has been sustained for more than 20 months now and is associated with major clinical improvements, where he's gone from needing assistance with walking to walking independently. He's had normalization of his sensation in his face and hemibody and improved hearing. When we look at the correlatives for this patient, we saw that he had initial expansion of GD2 CAR T in his blood, and with ICV infusions, those levels decreased but remained detectable. In comparison, his cell-free tumor DNA decreased over time with tumor regression. When we look at his CSF cytokine profile, we saw that he had a very pro-inflammatory CSF cytokine profile with elevations of TNF-alpha, interferon gamma, and that these elevations remain persistent with each repeated ICV infusion. The second patient I wanted to discuss is a 30-year-old female who had a spinal cord DMG and received 9 infusions. At baseline, she had a very large thoracic cord tumor that obstructed the CSF flow surrounding the spinal cord and led to her to be incontinent of bowel and bladder. She was wheelchair bound and required IV pain medications. 2 months after receiving her first infusion, she began to have significant tumor reduction that continued at 5 months. And by 9 months, her tumor was just a sliver, and that corresponded with a 91% tumor reduction. This was associated with clinical improvements where she began to walk with a cane, she became fully incontinent, and her pain was controlled with just oral pain medications. She, similar to our first patient, had initial expansion of the GD2 CAR T in the periphery. And unfortunately, though, because of personal reasons, she had to take a pause in her treatment. And during that time period, her GD2 CAR T in the periphery became undetectable. During that period of time, she also developed a new area of involvement superior in her cord. And when she came back for treatment, we were able to decrease the size of the primary tumor, but were unable to recapture that disease higher up. And then she had increase in her cell-free tumor DNA at that time of progression. Similar to the first patient, she also had a pro-inflammatory CSF profile that remained persistent throughout the duration of her treatment. The last case I wanted to highlight is a 4-year-old girl who had a DIPG and has received 16 infusions with both clinical and radiographic improvement that's been sustained for more than 20 months. At baseline, she had a very large tumor that, as you can see, is facing her fourth ventricle. There's limited CSF flow around the pons. And after just 12 months, her tumor didn't decrease substantially. In terms of the volumetrics, it only decreased by around 15%. However, as you can tell by this MRI, the tumor density has improved. There's increased CSF flow around the pons, and the fourth ventricle is a lot more open. Clinically, she had improvements that consisted of improvement of esotropia, improvement of facial diplegia, and improvement of her hypophonia and dysarthria. And this patient's case underscores the importance of patient-reported outcomes because although the tumor volumetrics did not change substantially, she had improvement in her quality of life, and that might also confer some benefit in terms of what these patients need or would like to seek out when looking at clinical trials. After completing Arm A, we then transitioned to Arm B and C. And because we had seen such high-grade CRS with the IV administrations of CAR T-cells, and we saw that ICV infusions were associated with a more pro-inflammatory profile, we decided to test ICV infusions with and without lymphodepleting chemotherapy. In order to test the least toxic regimen first, we did just ICV-only infusions without lymphodepleting chemotherapy. We saw that with this dose escalation, we were seeing higher grades of TN with higher doses, and therefore we realized that the maximum tolerated dose would be 50 million cells. Although there was initial response to arm B, it was less durable, and the median preliminary overall survival was only 14.5 months. Because we weren't seeing durable responses like we did with arm A, we then transitioned to arm C and introduced lymphodepleting chemotherapy back into the regimen. The first patient we treated on arm C, we used lymphodepleting chemotherapy plus 30 million cells ICV. Now, 30 million cells was the dose that we had used commonly as our first starting dose for the ICV infusions on arm A and arm B. However, when we gave lymphodepleting chemotherapy and then 30 million cells immediately afterwards, we saw that the clinical picture was more consistent with what we had seen with higher doses of ICV infusions of almost 100 million cells. We therefore realized that we needed to reduce that initial dose given the extent of the inflammation that was seen, and we switched our regimen to an interpatient dose escalation where we did lymphodepleting chemotherapy and then 10 million, 30 million, and 50 million cells. We've only treated 3 patients on this regimen thus far, but it has been much better tolerated with only max grade 2 TN, and we've seen clinical and radiographic responses in all of our patients. So it's early, but we believe it might be a promising regimen going forward. In summary, the lessons that we've learned from our time with this trial is that in order to safely deliver this therapy, we need a multidisciplinary approach, and therefore we are so grateful for the collaboration that we obtained with working with our neurology colleagues. And we've seen that GD2 CAR T therapy is associated with on-target, on-tumor inflammation with no concerns for off-tumor inflammation to date. We've seen that ICV infusions are better tolerated than IV infusions, but we may need lymphodepleting chemotherapy to induce more durable responses. We're still studying this currently with arm C. And we've seen that we can have clinical benefit and radiographic benefit with this therapy, and that might be due to the fact that in this tumor, the neural cells are causing dysfunction and not destruction, like Dr. Monje illustrated in her earlier slides. And durable responses will need us to better understand the tumor microenvironment and also understand the other things that might be at play, such as like myeloid cells and the neuroglial interactions that could be contributing to tumor growth and also resistance to the CAR T therapy. So I wanted to end by acknowledging all the people on our team. We have a lot of folks on the cancer cellular therapy team, neuro-onc team, neuro-immuno-onc team, neurosurgery team, neurology team. So we couldn't do it without all of you. And most of all, we're so grateful for our patients who have entrusted us with their care. So thank you.